All right. Hello, everyone, and thank you for attending Frankly Speaking About Cancer Precision Medicine. My name is Kelsey Allen, and I'm the Program Director with Gilda's Club Quad Cities. If you don't know about us, we are a cancer support community, and we offer a variety of programs and services that are all free to our members. The services include support groups, educational programs such as the one you're attending tonight, um, healthy lifestyle programs, social gatherings, and all of our programming is free. So I'm lucky enough to be here tonight with Dr. Muhammad Furqan from Iowa City, and I'll let him introduce himself here shortly. I am going to share my screen so we can get started with this wonderful presentation. I do want to give you a heads up that there is a link in the description for an evaluation. It takes about 2 to 3 minutes to complete, and this really helps us make sure we're doing our programs well, and it helps us with future grant opportunities. So tonight we are talking about precision medicine. Overview, what we hope to learn tonight is what is precision medicine, biomarker testing, using biomarkers to find the best treatment for you, types of biomarker-based or targeted therapies, the cost of biomarker testing and targeted therapies, and how to find the best treatment for you. These slides were medically reviewed by Gerald Messerschmidt, a medical doctor. And just a little disclosure, this program was developed by the cancer support community. We develop the content independently and then have outside medical and psychosocial experts review it. The cancer support community has final control over the content of this program, and it was generously sponsored by Bristol Myers Squibb, Foundation Medicine, and Genomic Health, and the presenter was engaged by our local affiliate, Gilda's Club Quad Cities. So disclosure, just stating that Muhammad and I were not paid by those Bristol Myers Squibb, Foundation Medicine, and Genomic Health. So I'm going to hand over the presentation. I'm going to allow Muhammad to share his slides and let him introduce himself and get started on his end.
Kelsey, do you guys see it correctly?
Yes.
Okay. So just to go over my disclosure again, and I am one of the thoracic medical oncologists at University of Iowa, and I have no financial disclosure for this presentation, neither from the Gilda site or any of the sponsor of this program. It's completely independent, and I chose to talk about this topic because I do see patients with lung cancer. That's my primary subspecialty. And precision medicine is one of the key in treating patients with lung cancer. And this topic is just dear to my heart. And I want to dedicate my time to increase awareness about this issue in patients, among even oncologists and my own colleagues, because the field of oncology is one of the most rapidly evolving field in the medical science right now. So it is hard to keep up even a subspecialty area, not to talk about the whole oncology or the whole area of internal medicine. So that's why I picked to talk about this topic. And one of the disclosure, I want to say that I want to keep this content as much as simple as possible. And keeping that way, it may be possible that I may cross the boundary of the terminologies in the medical sciences. I tried my best uh, to keep it the way it is simple and also respect the terms that we use medically. But some places that boundary may be, very close or crossed. So I apologize for that in advance because I intentionally wanted to keep it simple for everybody to understand in the audience. So precision medicine or personalized medicine, we hear a lot about it in the media, from the physicians, from many types of healthcare workers, and in the press. Basically, it is a way to make patients' treatment as much personalized as possible. Um, and you can just imagine in the past, patients with breast cancer, non-small cell lung cancer, prostate cancer, or colon cancer, they were all treated with one specific type of chemotherapy. But in the last 2 decades, things have evolved so much that in almost every cancer we talk about, there is a way to personalize treatment option for patient. Doesn't mean that that personalized option is just for that single patient, but it is personalized for a subset of a particular type of patients or cancer. And this personalization comes because all of us are unique, and like all of us being unique, and that's characteristic of the genes that we inherited from our parents and have those affected by our environment. The cancer, if get developed, is also very unique. It has its own specific set of genes, and gene is basically defined by a particular area of the DNA material that we all have in our all cells of the body. And this gene can be, we can talk about it as either a recipe or a manual that how a machine or automated machine can be made. It's not a machine itself, but it is basically a manual or a written instruction that how you can make an automated machine. And that automated machine product of the gene or an area of DNA material is called protein. So protein are the actual executor of function that goes on in our body, in our cells, every organ. If we don't have those protein, none of the organ can perform their functions. And these proteins, or for sake of the discussion here, automated machine in our body or in our cells, are derived by genes, which is basically a manual how these machine can be made. When genes are acquire an abnormality, let's say if we make missing a page in the book or missing a page in the manual, you can think about that the automated machine that's going to come out, whoever going to make it, that won't function properly. Either it will function much more than it's supposed to be, or much less than it's supposed to be, or it work very differently. Uh, that's what happened with the lot of environmental factor. Our genes are getting affected all the time. The most common or most important environmental factor is radiation, the ultraviolet radiation or other radiation that we receive from the cosmos in our universe and in our earth, that our body get affected, or these genes in our body get affected, and hence the manual or the instruction work for the protein machinery get upset or change, and these protein then lead to cancer formation. So we talk about gene, we talk about protein, and we talked about the genetic changes that happen. Not all genetic changes that occur in the genes that lead to the cancer are important. Some genetic alterations or changes are completely innocuous. They have no consequences. However, some changes are such that they can drive the cancer, and we call them, cancer driving mutations, and they lead to abnormally active or altered protein or abnormally present protein. In some cases, The example is there are protein in our cancer cells. If someone has a particular type of non-small cell lung cancer, and I want to give the example of ALK-driven non-small cell lung cancer, which is 1 to 2% of all lung cancer, they have a protein called ALK. Normally, that ALK protein is not present in our lung cells. However, due to genetic abnormality in the lung cells, due to radiation or some other environmental factor that we do not understand so well, that ALK gene start to make the ALK protein, and that ALK protein drive the cancer cells. So cancer cells are either driven by abnormally active protein or abnormally present protein. And these two concepts are the most important throughout our presentation or our discussion tonight. And these, both of them happen due to genetic abnormality in specific either genes or in the genes that control those genes. So we talked about this, that in the past, many of the cancer subtype, and I can give an example again, like a breast cancer or a lung cancer were treated by chemotherapy, and we used to call for lung cancer, for sake of example, platinum doublet, carboplatin or cisplatin with another chemotherapy. Nowadays, we are not doing so because of the uh, precision medicine or personalized medicine, because we learn about the biomarkers, which I'm going to define in the next couple of slides. And that's what all about the precision medicine or personal medicine. Uh, and these specific um, subtype of cancers basically have a specific biomarker or genetic makeup, or basically a different molecule which we could test, and that we will talk about in the next few slides. So every cancer, as I said, is very unique because the genetic makeup of each cancer is different. And that's why personalized therapy or precision medicine is very important. So what happened is when someone has cancer, uh, most of these patients undergo biopsy or surgical resection of their tumor area, and that tumor sample get tested in the lab. And the lab take the DNA out of the cancer cells and analyze for any genetic changes. Beside the genetic changes, there are other biomarkers or there are other molecules that are not gene by themselves, but they are directly protein. They can also be altered. So the lab analyze, in case of molecular testing, the DNA. But if we take a more encompassing term, which is biomarker, the lab can analyze the presence or absence of a special protein in a specific quantity as well. And based on that, they can tell the report to the treating physician or treating oncologist that this is what this patient cancer is make of, or this is the molecule that is driving the cancer in this patient, and then one can personalize the treatment option based on it. The purpose of biomarker testing, the main purpose of biomarker testing, or that molecular testing of the genes and the presence or absence of a specialized protein, is to come up with a best treatment option for the patient, because that treatment option will be very specific to the change in the gene or change in the protein that is present in that particular cancer. It's not necessary that that particular change occur only in a particular individual. As I said, this happen in a subset of a subset. For example, in non-small cell lung cancer, which is the most common type of lung cancer, there is EGFR mutation or there is ALK mutation. So patients who have those particular genetic mutation, either ALK or EGFR, all of those patients who have this mutation have very similar genetic makeup. So it's not happening in an individual in particular, but it's happening in a group of patients who have non-small cell lung cancer. And we'll talk about this in the later slide as well. Besides helping the selection of best treatment option based on the specific genetic alteration or protein, these biomarker tests helps predict the response of the treatment, help predict the response of the treatment option that is being chosen. And they also help prognosticate that what patient's prognosis will be if they take particular type of medication. In addition, beside the specific change that occur in certain DNA or certain genes, there are several other genetic alterations that are non-driver, that do not drive the cancer, but they are still present, and they influence their change. Those changes influence the main driver. For example, you know, um, in case of, again, non-small cell lung cancer, again, I'm taking the example of EGFR mutation or ALK mutation, or in case of breast cancer, who have PI3 kinase mutation. These cancer cells can have other genes that are also mutated, but those genes are not driving the cancer growth primarily, but helping the primary driver. And no knowledge about those genes in specific can help the oncologist or the treating physician understand the prognosis of the patient overall. In the last, beside affecting the treatment option, predicting how good the patient will respond to a particular treatment and prognosis, some of these driver changes can also help the diagnosis. This is uncommon that they help the diagnosis, but sometimes when they are present, they make the diagnosis very certain. There are some examples, especially in sarcoma, which is basically tumor of uh, bone or tumor of the fatty tissue in the usually happen in the thigh or in the belly. When these some particular type of sarcoma have particular type of genetic change, and if we do find the genetic change, we are very certain that we are dealing with a specific type of sarcoma. Without that change, sometime it is not very clear that what we are dealing with or what type of sarcoma or specific soft tissue tumor we are dealing with. So this is the table I composed, and by no means it is a complete table. uh, this is just an example that in particular tumor types, how many type of genetic changes exist. And all of these genetic changes that I put in this table, they are driver changes, means they are driving the growth of the cancer. They are not those changes which are secondary or influencing the primary one. They're all primary ones, and they are the driver ones. And if we target those gene in particular, we can really affect the tumor growth in those particular cancer type. However, they are not present in all type of tumor. For sake of example, breast cancer, BRCA1, BRCA2, PI3 kinase mutation that I just mentioned, these mutations or these genetic changes present only a subset of breast cancer patients. Same thing in lung cancer, non-small cell lung cancer, there are 9 different type of genetic changes that are listed here. Only one of them will be present, and those one are also present in a subset of non-small cell lung cancer patient. They cannot be present in all non-small cell lung cancer. Hopefully in future, we may find that all types of non-small cell lung cancer have a particular mutation that we could target, but currently we only know about these 9 alterations that can be used to target lung cancer. For colorectal cancer or colon cancer, there are at least 3 types of changes. These two are primary genetic changes. This one is not a genetic change in itself, but it's a product of a genetic change. Same thing in gastrointestinal stromal tumor. This is a gene that is altered, and it has a diagnostic value as well, because sometimes assessing the tumor is not very easy. So if this is present, this is confirm the diagnosis, like I was saying earlier. Similarly, in certain leukemia, especially chronic myeloid leukemia and acute lymphoid leukemia, this is the gene. It is basically a fusion abnormality that occur and can be diagnostic at some time. Similarly, in ovary BRCA1, BRCA2, in brain tumor, IDH, IDH2, prostate, very recent discovery. We know that these genes were present in some types of or a subset of prostate cancer. However, the treatment just got approved earlier this year. Cholangiocarcinoma, which is a type of liver cancer or a bile duct tumor, has this kind of genetic change. It's called FGFR fusion. Again, not present in all types of bile duct cancer, present only a subset of bile duct cancer, but the targeted therapy or the treatment that affect this gene just approved earlier this year. And there are some other genetic alterations like MSI high or deficient in mismatch repair protein or NTRK. These are the alterations that can be present in many types of tumor, and they can be targeted by a specific treatment options. So the knowledge about these genes is really important for patients who have these cancers, because it's really affect the treatment choice that their physician would pick. If they do not know or we do not seek these testing, then we may be treating suboptimally those patients. So the question for the patients or their family member to ask to their treating physicians is, am I eligible, or my family member is eligible to have a biomarker test, that so that they would know if there is a specific biomarker which is present or absent could influence the treatment. And if the biomarker can be tested, what are those biomarkers? And if those biomarkers are present, are they affecting treatment or prognosis or both or none of those? Because sometimes there are biomarkers that are not affecting these. I would stop at this point to take up any question regarding the biomarkers themselves, and then we'll talk about the treatment in the next few slides.
I don't have any Facebook Live questions at this time, but we have quite a few on Facebook Live, well over 10.
So Kesley, you want to?
I think you're
over, continue, and we can take the question in the end.
Yes, that sounds great.
Okay. So the targeted therapy, I was using this term earlier. Basically, if we use any type of treatment options to attack or to target a specific biomarker, we term as targeted therapy. As an oncologist, this term is not, it's kind of not very precise. There are vague uses of it. And there is a boundary that I may cross during this discussion. But to be in a strict sense, if there is a particular gene that is altered, and now it's leading to a protein which is also altered, and that protein is driving the cancer growth and is spread, and if we can attack that particular protein, then I would name any such therapy as targeted therapy. However, we can make this application of this definition a little more loosely, and any biomarker in the cancer that we can target by any sort of therapy, we could call it targeted therapy. However, it's not the precise way the term we use it in day-to-day practice or day-to-day medicine. So the targeted therapy, as I just said, that we are looking for a driver mutation. This is very, very important because, as I said, cancer cells may have several type of genetic changes. Not all changes are important, and not all changes have the same amount of importance if they are important. So that we are looking for driver mutation, and these driver mutation, if we target them by a specific therapy, then we can really influence the growth and spread of the cancer. For most targeted therapy, when we do use them, we want to know what type of biomarker is present. If we do not know, then using the targeted therapy will not going to be effective. And most of the time we don't use it. We are required to have the biomarker testing occurs before we prescribe or we talk about it. However, when we do use the targeted therapy, there is no guarantee that it will affect the cancer growth. However, I can say that 80 or 90% of the time it does. At least it slows down the tumor. Perhaps may not be to the extent that we want, but most of the time it does work if it's truly a targeted therapy. The issue comes, as I said, in the cancer cells, there is not one genetic change. There are multiple type of genetic change. And we divide those changes into driver, into non-driver but important, and completely non-important, or at least we do not know their importance. So if the non-driver but important gene are so many and they can influence the driver so much, then targeting the driver will not be fruitful. And that's what happened in some cases. But as I said, in 80 to 90% of the cases, these targeted therapy do the job what we like to. What do they do? In a true sense, they basically bind to the protein, because the protein is the executor of the change in the gene that occurred, or protein is basically the machine that actually perform in our cells. Genes are basically the instruction or the manual book of how that protein was made or how that machine was made. But protein are the executor. So binding those protein, and basically they bind and inhibit those proteins or alter their function basically. The other way these targeted therapy can work is by blocking the hormonal signaling, which is important in some cancer. For example, breast cancer, prostate cancer, certain uterine cancer, certain type of salivary gland cancer. These cancers drive their growth by presence of certain hormone in our body, mainly either testosterone or estrogen and progesterone in case of breast and uterus. So if we can block them, we can block the growth, or we can alter the growth of the cancers. In other cases, which is now I'm using the term targeted therapy very loosely here, that targeted therapy can can take away the brakes from the immune system. And I'll explain it a little more because it's more complicated than in just one word. It will be in the next coming slides. So again, going back to how targeted therapy works, they basically bind to the active protein, which are a result of an abnormal gene. And these are the examples. And all these examples are from, osimertinib, alectinib, crizotinib. They are used in non-small cell lung cancer. There are many other examples. Pemigatinib just got approved for cholangiocarcinoma. Um, Lerotrectinib, which was just got approval for NTRK-driven tumors, regardless of the type of the tumor. So these are the true targeted therapies. There are other treatment options that are, again, I'm now going to use the term targeted therapy a little loosely because the target is present in many cells and it's not specific to cancers. However, in cancer cells, they are present in excessive amount, and that's why I talked about two different type of protein: abnormally active protein or abnormally present protein. In case of this example, here the protein is not abnormal in itself, but it's abnormally present either in high quantity or relatively high quantity. For example, this medication trastuzumab used in the breast cancer who have increase in number of HER2, which is a protein. Cetuximab, we use it all the time in head and neck cancer, the tumor of oral cancer or laryngeal cancer, and it's also being used in colon cancer. And it's target a protein EGFR, which basically present in all the skin, colon, everywhere. It's basically present. However, in the cancer cell, it's present in excessive amount, and that's why we use it. Rituximab, it's another um, medication that we use in lymphomas, especially those lymphomas that have a particular protein we call CD20. Uh, so these can be called targeted therapy, but it's little loose utilization of the term. However, these treatments are still important because they are part of the personalized medicine. Before we use these medication, we want to know if the particular patient's tumor have these proteins or don't. If they don't, then using these therapies probably not going to work. The other example, which is very new and it's emerging in the last 5 years and really expanding, is basically using these proteins or these type of treatment and tagging them with a chemotherapy. So, and this is being used already in certain type of breast cancer, certain type of lymphoma again. And there is a new drug that got approved for bladder cancer this year, and there are many more that I know in the clinical trial right now. So basically, we utilize the same compound that we used here in the breast cancer, but instead now we are not using it alone. Like here, we have compounded it with a chemo. So basically, we are targeting cancer that has breast cancer in this example, which has HER2 protein on the cancer cell surface with a protein called trastuzumab. Alone, it will be effective, but now we have tagged this protein with a chemo part or chemotherapy. And now through this protein, we are delivering a chemo to the cancer cells. So basically, we are targeting chemo, which we in the past used to just put in the blood through the IV infusion, and it would go to every organ. Now, with this specialized way, you are delivering, or we are delivering the chemo through binding with a specific drug molecule that would bind to a specific area in the cancer. So now we are making these conventional chemo or traditional chemo to find the cancer in the body and attack it right there. Currently, this is approved for breast cancer. Currently, this is approved, brentuximab vedotin is approved for lymphoma. This is explanation how the hormonal therapy that we just talked about, that the hormones for some cancer really act as a fuel, especially true for the breast cancer, prostate, uterine, and some salivary gland cancer, and some benign tumor like meningioma and carcinoid tumor as well. Carcinoid is not completely benign; it's basically malignant, but there are certain hormone or certain chemical in our body that basically fuel the growth of these cancers. And in case of breast and uterus, these are estrogen and progesterone. In case of prostate and the salivary gland, it is testosterone, male hormone. And we can easily block them by hormonal therapy. So that's why I don't want to call them targeted therapy, though they are targeted. They are biomarker specific, but they are best called as hormonal therapies. The last example that I was making the point earlier that it's more difficult, but I'll go over in depth right now, is in a perfect system or in a perfect body, none of us should develop any sort of cancer. However, and that happened because our immune system is so well equipped that if any cancerous cell start to get developed, our immune system go and attack it and kill it right there and then, and that's it. So we don't develop any cancer. However, to check our immune system, there are certain breakpoints in the immune system, which body use it all the time. And I give the example, we every day in our life, we are exposed to eating a lot of things. We are exposed to a lot of things in our environment, on the skin, and a lot of time we breathe so many protein or so many things. So if our immune system start to respond everything that goes in our body, there will be a problem. And that's happened in patients with asthma. That's happened in patients who have a lot of allergies, because their immune system cannot distinguish when to stop and when to react. It should be reacting to something that is harmful to us, but it should be inhibiting itself when there is no way avoiding that insult. And in patients with asthma, in patients with allergic condition, immune system lose that boundary, and that's why they have this problem. And that's why our immune system develop those checkpoints to inhibit itself when responding will not going to make any sense. Let's say if I am eating wheat, which is basically a gluten, most of us can eat fine. But in patients who have gluten sensitivity or celiac disease, their immune system recognize gluten as a problem and start to react. So body have provided a checkpoint so that it does not respond to gluten in patients who are normal, who do not have celiac disease or gluten sensitivity. So those checkpoints are important. If immune system doesn't have checkpoint, many of us have immune problem, autoimmune diseases. Cancer is very smart. It used the same trick. It used those checkpoints to tell the immune system that I'm not the problem. I'm part of your body. Don't attack me. So it takes a disguise and act as part of our body while it is not. And our immune system tried to attack on it, but because of that disguise, the immune system, could not recognize that cancer cell as cancer, and that's why that cancer cell was able to develop in a full-blown cancer that we see in the clinic or we see in the patients. So these drugs, immunotherapy, basically target those checkpoints. And right now, there are several drugs that got approved. There are basically all of them are very similar to each other. The first five one, they are basically Tylenol versus the acetaminophen in our eyes. They are all same. They attack, which is a biomarker. We call it PDL1, programmed death ligand 1, and which is basically a disguise, and cancer cell cover itself with the PDL1 molecule. So these drugs, the first five one that I wrote here, they basically attack that protein and take that disguise away from the cancer cell so that immune system can talk to the cancer cell as an enemy and not as a friend. This is a different drug. Um, it's 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 a bind with the biomarker, but it's more a complex mechanism how it works. So I will not go over in that. So in a true sense, immunotherapy is not targeted therapy. However, when PDL1 is present in high quantity on the cancer cells, these drugs have much higher likelihood of working when compared to when it's not present. And there are examples, like in case of lung cancer, bladder cancer, when PDL1 is present in much higher quantity, the prognosis and the predictivity of these drugs to work is way different compared to when it's not present. However, in some other cancer, they work regardless, just because we cannot reliably measure that biomarker. I hope I made that point across because it's a difficult concept. So the question to ask, to the oncologist, again, or a treating physician, what type of targeted therapy I may receive, how long, how often I would receive, and would it be combined with something traditional, and what are the side effects. So many of us think, when we do use personalized therapy, they will have less side effect. Yes, in ideal world, yes, that's expected, but we'll talk about it. they do have side effects. The biomarker, again, I was talking about it. I used those terms in the past, in the past few minutes. That EGFR we can target by this drug. It's a pill taken once a day. ELK, another biomarker in non-small cell lung cancer, we could target by so many drugs. BRAF, very common in melanoma, uncommon in colon cancer and non-small cell lung cancer, we can target. ER or PR, estrogen receptor and progesterone receptor, they are present in breast cancer, uterine cancer. They can be targeted by the hormonal therapy. HER2, it's present in multiple type of tumor, especially important for the breast. But now we are discovering that it's present in multiple type of tumor, and drugs are coming for that. BRCA, um, there are already different PARP inhibitor that got approved for BRCA. It's present in ovarian cancer, breast cancer, prostate cancer, and pancreatic tumor. In pancreatic tumor, it's very small amount, small percentage of patients, but when it's present, it does make a difference. ROS1, a very uncommon or rare biomarker in non-small cell lung cancer, but when it's present, the prognosis of these patients is way different than patients who do not have any of those biomarkers. There are certain biomarkers that are not cancer specific and they can be present in any cancers. And the best example of this is MSI high, or we call it microsatellite instability or deficient in mismatch repair gene. We don't need to remember all those big names, but basically MSI high or DMMR positive cancers are very responsive to immunotherapy, and this is approved regardless of the type of the cancer. Unfortunately, the most, the presence of MSI high is concentrated mainly in the colon cancer. In the other cancer, we do not see this um, so commonly. Otherwise, it would have been very good for those cancers as well. It's mainly in colon cancer, very limited amount in, I would say, less than 1 or 2% in other cancers. NTRK fusion gene was a big hype last year in 2019 when the first drug got approved for this gene. But it's very, very rare gene. I have to say that less than 1% of any cancer would have this gene. So, but when it's present, it's very important for that one single patient because it can change the whole paradigm for that patient. So that's why the key point is testing the patient tumor cells correctly, so that way it get tested. The problem is there are many vendors, and I'll talk about this in the next slide. Some of the genetic panel that sometime provider use do not contain these genes or some other genes, and that's where the problem occurs, that we do not know how many patients out there who may have it, and we just do not know about it. As I said earlier, that these targeted therapy or biomarker based therapies, they are not innocuous. We expect that their side effect would be less because we are personalizing it. However, they have side effects, and I would say that side effect profile is just different, very different. They do not cause hair loss like traditional chemotherapy or mouth sores or change in the blood count that happen every cycle of the chemo, or fatigue that happen in a cyclical fashion. Once patient get chemo, usually they get fatigued for a few days and then they get better before the next cycle. So this cyclical changes is very common in traditional chemotherapy, but for targeted therapy, whatever problem happen, it's kind of persistent. It's every day because we do not give these personalized medication on a cyclical basis. Most of the targeted therapies are taken every day or twice a day. Some treatment options that we just talked about earlier, which are maybe not true targeted therapy, but again, they are biomarker based therapies, they are given every 3 weeks or every 2 weeks, depending upon the drug. And we may see some cyclical problem over there as well. But most of these side effects for biomarker based therapies, they are persistent kind of. And many of most of them usually cause rash and fatigue. This is the most common one. The others are very specific, and for the sake of this discussion, I don't think they are relevant. Biomarker-based therapies can be combined with chemotherapy, radiation therapy, um, or hormonal therapy, or sometimes two different biomarker-based therapy can be combined together. It all depends what we are dealing with. So here are, I put two examples. We talk about HER2 a lot during this whole discussion, which is primarily, as I said, is present in breast cancer. However, there are multiple other cancer that we are learning is it's altered or increasingly present or abnormally present. But in breast cancer, it's present in 20%. Basically, 1 out of every 5 patients have HER2 overexpression, we call it, or in a simple way, abnormally present. And it is not a true driver, but it influences significantly the growth of breast cancer. And if we can target it by multiple drugs, you know, at the time, you know, I think there are more drugs that can target it, and there is much more, uh, many more drugs are coming on the way. I know that because this target is now getting importance in non-small cell lung cancer, this targeted getting importance in esophageal cancer, colon cancer. So there is a lot of new drugs coming for this target. In case of non-small cell lung cancer, um, good news for many patients that the number, the list of the genes that we could target is just keep increasing. Every year we learn something. In 2010, we only have the first one. But now in the last 9 years, we have drug for all of these. And this is a completely new one in the last 5 years that we learned about PD-L1 basically to target through immunotherapy. So I put some percentages here to put things in perspective that either every non-small cell lung cancer, which basically comprise 85% of the lung cancer, have these alteration or at least 1 out of 3. It all depends if the patient had a history of smoking or they have never smoked. If they have never smoked, I tell my patient 99% of the time they have one of these. There are some alteration that we do not know, but they are it's very uncommon. So far, I have probably in my practice of 7 years in never smoking patient, I may have 1 or 2 examples where I did not see one of these. They can be difference, like this one is present in smokers and non-smoker. I would say almost equally, but different type of mutation. This is specific KRAS mutation. KRAS usually occur in 30% of non-small cell lung cancer, but 15% of them are G12C subtype. Now it's subtype of subtype we are talking about. So it's very specific in patients who never smoke or light smoker. It's a different type of subtype of KRAS, which we cannot target at the moment today. However, there are treatment options developing for those patients, and I am part of many of those clinical trials. So things are coming, things are changing. Many of them got approved this year, like for RET, the approval happened of 2 drugs this year, just in the last 2 months. MET exon 14 skipping, the approval happened 4 to 5 months ago, this year again. HER2 and a specific subtype of EGFR, we are expecting early next year. Um, for ROS1, there are 2 drugs that got approved this year. For ELK, again, there was a drug that got approved. For KRAS G12C, we do not have any drug approval, but 2 candidates are looking for FDA approval, I would say mid next year. So it's very promising. Things are just getting better, as the science discover more and more. In PD-L1 expression, it's not a gene, it's a protein that predict the response to the immunotherapy. If it's more than 50% present in the tumor cells, which happen in 30% of lung cancer patient, specifically non-small cell lung cancer patient, that's really a game changer for those patients. Their prognosis is 5 year kind of. We never heard of these 5 year. I never quoted in clinic when I started the practice, but I quote them now very often just because of this. So here there are some limitations of personalized therapy. As I said, they are not present in all, like we just talk about non-small cell lung cancer or breast cancer in more depth. However, even in breast cancer and lung cancer, not every patient with lung cancer or breast cancer have a biomarker. They may be just completely negative. For example, in breast cancer, we call the term triple negative breast cancer. Very common, you guys may have heard of it. So triple negative basically means they do not have estrogen receptor, they do not have progesterone receptor, and they do not have HER2. And that triple negative breast cancer is not uncommon. It's comprised, 1/3 around of breast cancer, depending upon what age and what is the family history, that geography or that epidemiological number change. But it's still there. However, those triple negative breast cancer patients, we are learning that immunotherapy works better in those cancer patients. And there are some other genetic alteration which we never thought of. So we should not be using triple negative anymore. There will be quadruple or you know more numbers because the number of targets are increasing. So triple negative was the term coined because there were only 3 targets at that time, but now we have more targets, so hopefully we go away from that term. But I don't expect that happen in the next few years. It's more of a decade story. uh, I hope it's sooner. Not all types or subtype of a particular cancer, we talked about this. And even if the biomarker is present, doesn't mean or it doesn't guarantee just because we have to be dependent on other genes that are abnormal in a particular tumor, though they are not driver, but they still influence the driver. And other limitation that most of these biomarker or targeted therapies, they are not cure again. We are still buying the time, and unfortunately I have to say that uh, they are not cure yet. We are hoping with immunotherapy we can use the term cure because I have now a bunch of my own patients that are 5 year beyond, and they have so-called terminal lung cancer, or many of my colleagues in melanoma have patients with melanoma who are at some point were told that they have terminal melanoma, but now we call them cure because they are 5 year beyond. So hopefully we would use or we come out of this is not cure, but at this time I want to be cautious. I don't want to use that we can cure yet, but hopefully immunotherapy is changing that narrative because we are seeing more and more. The other issue with biomarker-based treatment is testing and treatment both are expensive. Um, I don't know if I should stop or keep going, Kelsey.
You can keep going. We have no questions on Facebook Live.
Okay, so I briefly want to go over the cost issue just to explain. Most insurance companies are okay with testing because I think as the patient community, as the physician community, we are learning that this is so important. So the insurance companies, Medicare, they all realize that can change the life, of the patient. So they are increasingly coming on board, and I have not seen that any insurance company, at least in Iowa, would say no. Or in Illinois, we share a lot of patients from Illinois, or in neighboring state, they would say no. Medicare would have not yet. Um, so they are getting on board. However, they would pay for the actual cost or their share, but sometimes copays of these tests can be very significant, and that's the patient component that patient have to pay, and that can be prohibitive sometimes. However, I think many companies who are testing. I don't want to name any companies here, but the physician usually knows those companies um, who order these tests very often, that which company can work with the patient on a financial terms, either to forego the copay or put it in some sort of the way that it's less burdensome, or completely write off or put it in installments, things like that. um, the other option is through the clinical trial. Patients going in the clinical trial usually get their biomarker tested, kind of one of the eligibility criteria. So it's a one way, but I don't think anyone used this for that route. It's inappropriate. And I don't think the first two, I have never found that I have to sneak in from the system. It's usually okay. But many patient advocacy group and many centers have some program as well if there is a problem occurs like that. Beside the testing issue, there is a second issue is the treatment itself, because the treatment is also expensive. And when they are expensive, again, I would say that most, I have yet to encounter a company that would say that they would not pay for the drug. I'm talking about the insurance companies here or Medicare. But again, the copay portion that falls on the patient's shoulder sometimes can be prohibitive to use the treatment. In most cases, at least where I am practicing at university, we are able to get by those problems because of access to grants from a lot of societies, or other. And I think most places can get by without this issue. But at some places, this could be a problem. So I just wanted to put out there. And that's why the support community, like, that's where the, you know, their help come, or American Cancer Society, or, all of these societies, every cancer has their own societies. They all have grants for these particular patients. And I want to say the pharmaceutical companies are also very cognizant about it. Yes, their drugs are very expensive, and I'm not talking in favor of them, but they do have program for patients when insurance company completely denies, or when the copays are prohibitive. I found many pharmaceutical companies, without doubt, they all have, we call them medication assistance program, and they can help with the cost. I wish they make it free. That would be the ideal world, but they have to cover their cost of developing the drug, which is in millions. Here I will switch gear. We have less time. I went over, I think, in more detail, or did not account for the time, yeah. But quickly, I want to say, so far what we were talking about, checking the genes of the tumor. Right now, the topic is checking the genes when there is no cancer in the body. And right now we are talking about genes that are inherited. These genes are, it's present, but that doesn't mean that there is a cancer present in the body. However, they are telling us as a provider, or they are telling the patients that you are at higher risk than rest of the population for developing certain cancer if you have inherited a particular type of gene. And we will go over those. So when we talk about biomarker testing, we're talking about cancer genes. And I put here because the terms are vaguely used. In a strict sense, I don't think we as a, as a physicians, or, who are in the field, we use the term germline or somatic. We don't use any of these terms, just so that everybody on board. Germline means inherited, somatic means in the tumor specifically. So here, whatever we have covered in the previous topic, it was somatic mutations, which I put here, basically present in the tumor. Germline means we have inherited, and those inherited ones are important in someone who have the family history of certain cancers. Is usually, at least at this point, breast, ovarian, uterine, colon, pancreatic, prostate. If anyone has a strong family history of these cancers, they need to ask their physicians that can they be checked for genetic changes if they are at higher risk of developing that cancer. Because if they are at higher risk, there are things that can be done. Means in patients, in women who have inherited BRCA genes from their parents, they can go for a surgical removal of the breast tissue. Mastectomies, prophylactic. Just for prevent the developing of the breast cancer. And many patients have at high risk for colon cancer because they have certain genes. We call there is one gene, FAP or FAP. It's common. TSC is another gene, and there are other genes. The Lynch family genes. If they are present, they need to have their colon removed just to prevent colon cancer, or if at least if we are not going for removal of those organs, then at least these patients can undergo more frequent or more stringent screening process. So that way, if the organ are still present that could develop cancer, we can at least find the cancer early on and remove it quickly rather than at that being in a later stage or advanced stage. So I talked about BRCA gene. It's important for breast, prostate, and pancreatic and ovarian cancer. So this can be germline, and this can be somatic. And when it's somatic, there are treatment for it. When it's germline, we don't treat. We basically counsel the patient either for increased screening or removal of the organ at risk. So the key message that I wanted to deliver is that I think every patient with cancer or their family member should ask the treating physician or treating oncologist that can tumor of my family member or if patient, can it be tested for biomarkers? Number one. Number two, these tests preferably need to be done on the tumor tissue itself as opposed to in the blood. There are discussions and there are being tests that are just on the blood, not itself on the tumor, that could detect these changes, which is very, very good for a lot of patients because sometimes tumor tissue is not feasible to obtain or just not available. That's very good. However, those blood tests do have a downside that they are not 100% like the tissue. So if tissue is present or the tumor sample itself is present, it's preferable that genetic testing being done on the tumor itself. If not present for whatever reason, then liquid biopsy, we call it, or blood-based testing or serum-based testing is completely fine. Those serum-based testing do have added advantage that they can be done more frequently and can be used for multiple other reasons. I don't want to go over that part right now. The other thing I want to mention, in the past, it used to be that many labs, and it's mainly for physicians, but I do see it all the time, and it's really frustrating sometimes in the clinic that still there are labs in today's date that they are doing one single gene and they check for 2 or 3 genes and they are not using the broad-based genetic panel, which is very, very important. There are companies, again, I don't want to make a comment or name them. There are companies that check 300 genes, 200 genes, 100 genes. I would say anyone checking more than 25 or 50 genes, it's good, but should not be below this because then we are talking about those panels which are likely to miss something important. And that importance is keep increasing on a daily basis. There are several genes we didn't talk about because those treatment for those are not yet available, but they are being developed. So knowing that alteration being present, at least those patients can be referred for clinical trial elsewhere. So that's why that is important to know. And the second part of this whole discussion is that family member of patient with a history of certain cancers, and I name these four. I think we could add pancreatic. There can be some more cancers that can be added here, but these are the common examples. I thought I should name them. their family member should ask the physicians that can they be tested for germline or inherited gene that can put them at risk of developing cancer in future. And here I end my talk, and I give the mic to the Kelsey.
Thank you so much, Muhammad, for all of your knowledge on this topic. I think it's a very popular topic. We had over 30 people tune in to listen to this presentation. So I am just going to share my screen to share two last resources, and we'll finish with questions here in a minute, and then we'll get off live. So one moment, and I will share my screen. Okay. So the last two resources that I want to share with you is the Cancer Experience Registry. This is a research survey to identify and understand emotional and social needs unique to the cancer experience. So the results from this survey informs medical professionals about the patient needs to improve quality of care. And this is all over the United States. So it's a really great way to make your voice heard. How do you do that? You can go to the Cancer Experience Registry, and we actually have a link on our Gilda's Club Quad City website that you can just go to our website, and it's under our support link. There are 3 easy steps to get registered. You fill out your survey, and it's your way of setting up a personalized page and check back for educational resources. So once you complete the survey, you can go back to your website and they will provide resources individualized to you based on how you answered those questions. So just a really great resource. The next resource is My Lifeline, and this is kind of like a personalized blog. It's an interactive blogging for updates. It lets your family and friends know how you're doing, so you're not sending out mass texts and kind of keeping everyone posted. You can just post and keep this one website up to date, and everybody can get email updates if you make any updates to your page. There's a helping calendar, which kind of you can coordinate rides to and from your medical appointments, assistance with children. You can even set up like meal plans and stuff like that. There's a discussion board, and you can have care coordinators. So you can have family or friends in charge of the website for you to make it easier. And then you also control who gets to see this page. Since it is private, you can control who you're allowing to view your website. So just a really great resource. But I have been checking Facebook Live, and I didn't see any questions. Like I said, we had well over 30 people attending tonight, so thank you so much. I am going to end Facebook Live, and we'll just go back to our Zoom to answer any questions.